So here we go. Thank you very much for the kind invitation to talk about the movement disorder in HD and very importantly about some of the management options we have to help people. As Bernard already alluded to, HD is a mixed movement disorder, which means apart from the chorea, which very often gives its name, it invariably in most people consists of dystonia. People are slow, like you see in people with Parkinson's disease. Especially young patients may have something that you call myoclonus, which is twitches similar to what all of us sometimes experience when we're about to go to sleep. People will become clumsy, which causes all sorts of problems in day-to-day life. Swallowing may become difficult, as does gait and balance. And patients very often will be prone to falls with all the consequences that this may entail. I am not going to talk very much about the swallowing disorder today. I'm not going into very much detail when it comes to the gait and balance disorder. So this is a lady in her 40s, and she's been having symptoms and signs of the disease for about 10 years. And what you can see here is the typical dance-like features that Bernard already mentioned. She's also slow when she pretends to play the piano, and you can see the chorea affects the whole body. So it's not limited to one region of the body. It affects the face, the trunk, the arms, the legs, the mouth, and the tongue. So this is a young man in his early 30s, and he's had symptoms since his late teens. So this is quite different to the lady that we've seen before. So he is predominantly slow. There's very little chorea to see. He has a slight shakiness of the fingers, dystonic posture of the fingers. But the main feature is that he looks very similar to a patient with Parkinson's disease. I cannot see very much chorea, and here you can see he's very slow. And if you're as slow as this with your hands, you can imagine how this impacts what you do with the hands in your daily life. Again, this demonstrates the slowness in alternate movements. And here you can see how he walks. Again, he has no arm swing. It takes him a number of steps to turn around. You really worry that he might stumble over something and fall. And he doesn't really move his upper body very much. So he walks like somebody with a hypokinetic rigid disorder. So the next video. This video I'm going to show you to illustrate the characteristic eye movement disorder of Huntington's disease. So this woman does quite well on the horizontal plane to follow the finger, but she struggles to follow the finger vertically on up gaze, for instance. She also struggles markedly to move the eyes on her own without any trigger. So if she's asked to move left to right or up and down, she can hardly do this without moving the head. Here you can also see that even to look between the fingers is difficult for her. So she struggles, is very slow, and there's some dyssynergy with the eyelids. This is some saccade initiation when the saccades are triggered by the finger movement. And again, it's easier for her if she initiates the movement using the head, when she struggles to just do it with her eyes. And the saccades are very slow. The problem is more pronounced on up gaze than in the horizontal plane. Now, this is a woman in her very early 30s. She's been having signs and symptoms of HD since her mid-teens. She's in late-stage disease, and what you can see is she's bed-bound. She adopts a permanent dystonic posture of her feet. She has what you might call striatal toes or pyramidal signs, a positive Babinski sign. I find it sometimes very difficult to distinguish the toe. And what you can see in her hands also is the marked dystonic posture. This is something that's difficult to distinguish sometimes with spasticity or the fixed postures that patients may adopt when they can't move the legs, the limbs. And if you don't have physiotherapy that helps them to always move the joints, the joint movements will be limited, and this can be very painful. But I'm showing this video because this is something patients that we don't really regularly see in outpatient clinics because they live in nursing homes or in chronic care facilities. And I'm showing the video to show that the phenotype, the motor phenotype, is quite different to the other patients that I've shown you. Okay, now I stop sharing again. Start sharing. Go back to my presentation. Now, why does it not move? There. So one feature that Bernard has already tried to illustrate is that the motor phenotype, not just everything, the whole phenotype of HD, but the motor phenotype can be very different between individuals. It differs depending on when patients develop signs and symptoms of the disease. So the age at onset makes it different to how your movement disorder is most likely to be. So the earlier you develop clinical signs of the disease, the more likely the phenotype seems to resemble what you see in Parkinson's disease. Whereas if you develop the disease later in life, it is more that of the typical motor phenotype that we all know from Huntington's disease. This is important because you may see patients in your clinic in whom you don't really know the diagnosis. So it's important to consider the diagnosis of Huntington's disease in a young person that develops atypical Parkinsonian features. The phenotype also differs depending on disease duration. So whereas in a typical patient, the hyperkinetic movement disorder may be more prevalent very early on, if you develop late-stage disease, as the woman in the last video, the hyperkinetic features of the movement disorder seem to disappear, and the phenotype is predominantly hypokinetic and rigid, and may include spasticity and other features. It is really important to develop a good management plan to assess the patient first. So it's important to describe the phenomenology of the motor phenotype using the skills of a movement disorder expert. So you describe what you see. You really want to know, how does the motor phenotype affect the patient in their day-to-day activities, because this determines the urgency with which a treatment needs to be instigated. And it's important to always remember that very rarely the movement disorder is the only problem of the patient and the family. So it's a key question is, which other problems exist and who has these problems? Sometimes the perception of the patient and the carer may differ quite markedly. Part of the assessment should always be a medication history. So you would like to know what has been tried before, if anything. For how long has it been tried for? What has been the maximum dose? What were the benefits? And what were the side effects? It is important to recognize that there are a number of factors that can influence the motor phenotype. It's worth considering that, as in all of us, when we are stressed, we become a little more fidgety. The same goes for anxiety. If you don't sleep well, you're also a bit more nervous. And the same is true in patients with Huntington's disease. It is sometimes helpful to think of how can stress be alleviated? Could you do something to treat anxiety? Could you help people sleep better? Because all these interventions may have a beneficial effect on the movement disorder before you've given medication to patients. To develop a management plan, it's important to develop a hierarchy of problems. So how do the problems rank in order of relevance for the patient and the carer? It's important to be clear on what is the main problem. The main problem may be the movement disorder. The main problem may be something different. It may be the behavioral phenotype. It may be the psychiatric problem. It may be the swallowing disorder. It may be all sorts of things. It is important, of course, to think of those problems in order of relevance. When you've developed that list of problems, it is then important to define your treatment goals. So what is the main goal? What are you trying to achieve? How are you going to measure the effects you would like to have, and determine when you're going to do this? The same goes for the secondary goals. Another thing that I find very important is that one should, in my experience, agree on what we expect from a given treatment, and agree with the patient and the carer to develop realistic expectations. Now, this is a biggish table that summarizes the treatment options that we have. I don't want to go through all the individual options, but I would like to highlight a few things. Very often, if patients first come to see me, I note that for probably any sorts of reasons, they have been put on a number of drugs. So they come with a huge cocktail of medication. Very often, reducing medication or taking patients off medication can be just as beneficial as starting something new. This is why I highlighted here the word reduce. An example is dystonia. Dystonia can be part of the motor phenotype of HD, but it can also be a side effect of neuroleptic or tetrabenazine. So unless you know how the patient was before that sort of treatment was begun, you don't know, is this part of the disease or is it a side effect? Sometimes the only way to find out is take patients off the drug and see what's left over. Then you know what is caused by the disease. I also highlighted physiotherapy as one of several non-pharmacological treatment options. And physiotherapy is something that does not come with side effects such as you observe with medication. And it can be very useful for, especially as one example, for the gait and balance problem. It's probably the best treatment we have for that part of the motor phenotype. So I have a few take-home messages. In my opinion, it's really important to distinguish the clinical problems caused by the disease from those that may be caused by medication. As I said earlier, sometimes the only way to find out is reduce or stop medication, and then you will know. If things get worse, when you take people off medication, you know that that medication, that drug is doing something good, and it's a good idea to stay on the drug. It's also very important to be clear what one wants to treat. Just giving something because you feel you need to do something, I don't think is a good idea. It is probably wise to use medication judiciously, knowing that giving less is often a lot better than giving more medication. I understand the difficulty of not always giving something, but sometimes it's best to do less rather than more. Very important it is to always make use of the non-pharmacological treatment options. So to don't just give a drug, but think of the availability of physiotherapy for the motor phenotype, speech and language therapy, if swallowing is a problem or language is a problem, it is key for a good management plan to define the treatment goals. If they're not reached, it's probably best to stop the treatment and agree so before you start the treatment in the first place. This does not mean that the problem has gone away. The assessment of the problem may be perfectly fine, but if your first treatment hasn't worked, it's time to stop that treatment and think of an alternative. Thank you.